So again, going back to the history, the importance of kind of assessing for cardiac risk factors, where, if they have pain, where it might be going, when they have symptoms, like nocturnally or diurnally, what other kind of associated symptoms, whether fatigue or edema they might have. I mean, of course, in any cardiovascular exam, you should be assessing for edema, right? I mean, you should take their shoes and socks off, right?
Yep.
I have my mother-in-law, Hilda, and they didn't take her shoes off. She's 82. God knows what could be hiding under those socks. So yeah, it's weird. That's how you kind of see exams done, right? They're kind of quick. They don't take most of the clothing off. Not best practices, we're going to say, right? So inquiring also about comorbid conditions, past medical history, family histories of cardiovascular disease, right? We know some of these are the risk factors for cardiovascular disease, or peripheral vascular disease. And some of these are, obviously some of these are modifiable, and some of these are not modifiable. What's not modifiable?
Genetic.
Age, gender,
Age.
the age again.
Family history.
I guess you can't really change them, right?
Your genetics.
You barely change yourself. Okay. Someone said genetics, right?
Yeah, you
Someone
can't
said
change your
genetic.
genes.
You gotta be careful with that because we find that not a lot of things. Yes, you probably cannot change your genetics per se, right? But you can change gene expression.
Yes.
So that's what I think we have to really distinguish, and that probably matters most. Because you're most likely going to realize like congenital or genetic problems very early in your life, right? You don't tend to carry them later into life. They'll be kind of obvious, right? They're going to see obvious chromosomal disorders or poor expressions, right? But you can modify expression, and we do that by a lot of different ways, and we usually do that by
Exercising.
Healthy
eating
lifestyle.
well, the environment is what modifies our gene expression. So it could be foods, modify gene expression. Why do certain foods prevent cancer? What is the
Because they're
mechanism?
high in antioxidants.
Antioxidants.
What does that mean?
They're
So it's
cancer-fighting
not
agents.
probably like we create free radicals and we just have to consume enough antioxidants for every free radical generated. That's not probably possible.
Right.
So most of these chemicals modify gene expression. Those colors in food modify gene expression. So you have your own antioxidant systems get turned on and off, and you have to keep genes that might cause excessive growth inhibited. You have to keep those genes off. And if you want to prevent cancer, keep those genes off. Right? And turn them on just in the right time. You only open an umbrella when it's raining, or maybe or if it's sunny, parasol, but you never have frills around it then, right? So then there's very specific times, but otherwise you want it closed. And that's what it is. You don't want access to gene expression openly. And the way these things prevent cancer is by controlling the expression of certain genes. And it's usually, in this case, by inhibiting genes expression. So genetics is kind of tricky on that, right? It's not so simple, right? But it is possible because we know that these changes in genes, right, that the expression of them, they can be transferred from generation to generation. So if I'm a male and I have sperm, right, and my sperm meets an egg someday, right, I will transfer these epigenetic markers, right, to that egg, right, and they'll join together and live happily ever after, right, and then a child comes out with these same epigenetic markers. But over time, by continuing to have environmental exposure, you change those epigenetic markers. But it takes a lot of time. So we follow the same thing, right? General assessment, inspection, auscultation, palpation, percussion. Then we do a little bit more in the cardiovascular and some a little less, right? Okay? I was about to pass out or something. So again, same thing, history, we talked about that, assessing for these. So this is health promotion moment just in. So we have to be dealing with hypertension. I think this is just a reminder for this. Just in. So this is how you would treat it. And you're going to be getting more about treatment on there. And I think we're all, you know, there's obviously, ones that are being changed all the time with this, right? So, there's guidelines that help us determine this, right? And then there's new recommendations here. So cardiovascular, no, also, you know, adjusting lipids as well too, and being able to control whether it's cholesterol. Cholesterol is not a simple thing, right? There's LDL cholesterol, HDL, and there's very low density lipoproteins, right? Usually when we're saying HDL cholesterol, we're measuring what?
The good cholesterol.
Well, we're measuring cholesterol in a high density lipoprotein. So we're distinguishing between the two, right? Low density lipoproteins are smaller and they have more cholesterol in it, and they're prone to more oxidation.
Less protein.
So a lot having to do with problems with lipid is oxidated fat, right? Which is pro-inflammatory. Because if you look at plaques, they're all the fat in there and cholesterol is oxidated. So, and HDLs tend to be larger, less prone to oxidation. We did some risk factors on here. And then we're determining risk factor for coronary, coronary heart disease, based on different things related to lipids and when we should be treating and what drugs are in there, right? So our roles are somewhere in a combination of this creativity of the interest of diagnosing and this theoretical to kind of following guidelines, like they're kind of cookbooks and stuff like that, right? So we do a little kind of combination of this kind of work. And if you're not following guidelines, is it okay to not follow guidelines under any circumstances? You say no. You say no. Anyone want to say yes? You say yes. You cannot follow guidelines. Remember, they're only suggestions on how you should treat patients. But I would suggest that you document a reason, a good reason why you chose not to follow a guideline.
Yes.
And that's fine, because remember, you can only have a malpractice suit if what occurs. Well, what is malpractice? I know we're getting into legal. Did you guys ever cover legal
Not
stuff?
yet. Not yet. That's
So first you have to establish a relationship with the patient, correct? So when you go into the patient's room, hi, I'm this, when they show up at your office, have you established that kind of relationship?
Yeah.
Yes. If they're in your clinic, you've established that relationship that I am a provider and you are a patient. Everybody kind of knows what they're there for and they expect. So that's it. The relationship is established. If your auntie comes to you and says, can you prescribe my blood pressure pills, have you established that kind of relationship with them? Yes, you have legally. Maybe auntie won't sue you, but you have established that relationship. Anybody you provide care to, you have established that relationship with.
But even if you haven't met him,
Tell me more about that.
if you haven't met the patient, if the patient is in your office.
If they're in your office, right, if you have not seen them and done
Oh,
anything,
that's
but
what
if
I
they're in
mean.
your office, that relationship
Oh,
is
okay.
established. If you've seen them last time, but you haven't seen them today, you still have a relationship established.
So you already met him.
Right, but if they're there, assuming, you actually meet them, right? If you can't, if they run out 2 minutes later, screaming, right, and they say, I'm suing them. You say, what? You didn't even see the person. Right, no, that wouldn't be the case. But we're talking generally the relationship established when they come there. I was like, what kind of care is that? That's like beyond telehealth. I give care to people I don't even know, right? No, something comes in a black box and I just throw a prescription in there and they take it on the other side and run. So then what else would have to occur for malpractice? Error. Well, that's not, let's say it has to be harm to the patient. Errors can occur and there's no malpractice. It's not good practice, right? But it's not malpractice in the liability perspective. There has to be harm. The patient has to have been harmed. But harm is kind of open. It could be, mental stress. It could be psychological harm, which is very hard to define. It could be physical harm. So harm has to occur. A near miss is not malpractice, right? Not good practice. It's not. Then what else has to occur? Doesn't have to be the wrong intention. It's not necessarily intention.
Can it be neglect?
right? Well, it could be neglect, right? So the harm has to occur a result of something you did that was not in alignment with the standard of care. That's important, right? You can harm people within the standard of care and you have not committed malpractice. Is that true? People can have side effects from medications all the time.
Yes.
The standard of care would be to warn them against side effects, especially you could die from this medication. You know, you could bleed out if you're on warfarin, right, and you fall. And they would say, oh, you know, or and the family comes back and says, you prescribed this warfarin, and if they would have fallen, they wouldn't have bled out. So you wouldn't be, as long as you did it for the right reasons, there wouldn't be malpractice. It would be something, so guidelines start to become the standard of care. And deviations from the guidelines become lack of standard of care. And standard of care doesn't have to occur nationally, it's not always global. It can even be regional standards of care. So that's why if you're going to move away from guidelines, it's important to document a reason why you have not followed them. Because you're going to be at the risk for not following standard of care.
That holds up more in a court of law than getting away from guidelines, right?
Tell me about that, yeah.
Like following guidelines, that it's if you do get sued or anything, it holds up better in a court of law because you followed guidelines.
Well, that would be standard of care.
Standard of
Our
care,
standard
exactly.
of care for treatment of lipid disease, or we're going to follow these indicators. They still may not work, and you may change medications, and things may happen, they may get side effects, but that happens, right? But it doesn't mean a good reason why you didn't follow, like maybe they have some contraindication to it, or the risk of treating by the guidelines would be more harm for them. But document it, you have to document it. So that's what I said, we're going to get these guidelines, you're going to have to memorize more of these guidelines when you get into those courses where you're doing treatment on there. This is to give an idea of how guidelines relate to our assessments, physical exams, and so peripheral vascular health, right? So that is, of course, the peripheral vascular, is part of the whole system along with our the central vascular system. The difference between arteries and veins, that's kind of very basic stuff, right? You've all had like pathophysiology, right?
Yeah.
You did this, you know all this. And so you know all these. So, layers of blood vessels, I'm not going to go through this because this is not really what our primary purpose of the course is here. This is just a review of this. You should be very familiar with this. So we have arterial insufficiency versus venous insufficiency. I think a lot of this stuff we kind of, how it might differ in symptomatology on there without even identifying the cause of it per se, right? How it might physically look, right? You're going to notice maybe differences in symptoms or differences when symptoms occur, or you may notice some varicosities, maybe with a venous return problem, which because arteries maybe are deeper, you won't notice those as well. Or obviously with an artery, you're going to notice maybe a pulse change. These are just different types, and this is important to know peripheral vascular disease. Again, we're still on difference between arterial disease and venous disease, so that's just important to know just in general. Anybody have any questions on differences? We've kind of heard all these before, whether it's nursing school or... So this is something we do, an ankle brachial index. This is where we are with slides, because I can show you a video on this. 72. We're almost done. Feeling good about that? Yeah. No. Me neither. So checking the pressure between the two. Does anybody know how to do an ankle brachial index?
You take the blood pressure up, and then you put a Doppler.
Okay.
You inflate it until you don't hear it anymore, and then you do 30 millimeters of mercury more. And then you get, I guess, the first quarter cough sound, and then you do it on all 4 extremities.
Okay.
And then you are supposed to get the average out of like both upper extremities.
Okay, yeah.
The average of both lower extremities. And then there's like a ratio where you like divide it and all that.
Ankle over the brachial,
Yeah.
right? So you're going to be doing ankle. We're supposed to be checking down here.
When I was reading, they said they did both popliteal and the dorsalis femoris.
Or you need the posterior tibialis? Let's see if we have this. I think they have a video on this. We got it. Let's see what this is. This is kind of a cool one. This is a super low budget test. Takes a little time. Not too much time.
Welcome to a Stanford Medicine 25 video on
Sounds
ankle
so sophisticated with this
brachial
music in front. I like it. Oh, Oxford.
Very Ivy League.
Hi, I'm John Cook. I'm a professor of medicine in the Division of Cardiovascular Medicine here at Stanford. And today I'm going to show you how to detect peripheral arterial disease in the office setting using the ankle brachial index, which is simply a measure of ankle pressure divided by the pressure at the arm.
Okay? Ankle over brachial, arm pressure, right? So remember, we're always looking for stuff that doesn't require so much testing, expensive testing, something we could potentially do in our office.
There are about 8 million people in the country with peripheral arterial disease, but only about 30% have been diagnosed. But with a simple handheld Doppler and a blood pressure cuff, measurements at the ankle and at the arm can give you an ankle brachial index to tell you whether or not the person in your office has peripheral arterial disease. Everyone over the age of 60 and anyone over the age of 50 that's diabetic or smoker should have this test done to determine if they have peripheral arterial disease, because we have life and limb-saving medical therapies for these individuals, like ACE inhibitors and statins and antiplatelet agents, and even beta blockers can be used in patients with peripheral arterial disease. So let's get started. So for the ankle brachial index, we need a handheld Doppler.
Okay, that's not a big thing.
And we also need some ultrasonic gel,
Comes with the kit.
and we need blood pressure cuff.
Got it.
We want the patient in a dimly lit, quiet room for about 10 minutes, relaxed, so the blood pressure stabilizes. Okay, so what we're going to do first is measure the pressure at the arm. And we're going to use the same technique to measure pressure at the arm that we're going to use to measure pressure at the ankles. So I'm putting the blood pressure cuff around the arm right now. You want it to be snug. And now I'm going to put some ultrasound gel right here in the antecubital space over the brachial artery. So my fingers are on the brachial artery there. Having done that, now I can listen for the signal with my handheld Doppler. Now, that's a nice signal. It's a normal triphasic pulse waveform that we're hearing with our Doppler. Okay, now what we're going to do is we're going to blow up the blood pressure cuff until we no longer hear a signal. Okay, and we're going to gradually release the pressure until we hear the signal again. Okay, he's got a blood pressure of 100 millimeters systolic. So that becomes our denominator for the ankle brachial index.
So that's very common, right? That's how we assess blood pressure, right? The reason I use the Doppler is just better than our ears, right? It gives a standardization where listening would be more subjective.
Now, there are two vessels that we're interested in measuring.
What are those two?
Precise space and
Got it. Okay.
The ankle brachial index. So two vessels in the foot. One is the dorsalis pedis, which is right about here where my finger is. The posterior tibial is right behind the medial malleolus. If you can't feel the dorsalis pedis bilaterally, it could be normal. That could be a normal finding. But you should always be able to feel a posterior tibial artery. If you can't feel the posterior tibial artery, that's always abnormal. So,
Okay, so remember, you might not have the dorsalis pedis. It's possible.
once again, you apply the blood pressure cuff. And in this case, we're going to be applying it right above the malleoli. And again, you want it snug. And you'll put the gel right behind the medial malleolus and over the dorsum of the foot. So let's just take a listen to the waveforms here. So that's a very nice pulse waveform, strong, biphasic, and that's normal in an adult. And let's just take a listen over the posterior tibial. Nice pulse waveform there. Now, let's check the pedal pressure. Okay, I've blown the cuff up and I'm slowly releasing it. And that was about 110 millimeters of mercury. That roar that you just heard, that was venous return. I'll actually demonstrate